Today we will have a seminar presentation on acid-base disorder. As you know, acid-base disorder is not a very common problem in surgical practice, but often we come across such patient in critically ill patients, and we should have a working knowledge of the basic acid-base disturbances and their management. So this seminar will be presented by Dr. Shobik Das, who is a junior resident at SSKM Hospital. Dr. Prosenjit Basu is a junior resident at MR Bangur Hospital, and Dr. Behrul Uda is in the Southeastern Railway Hospital. The session will be moderated by Dr. Ditiman Moitro, who is Associate Professor of Surgery at Calcutta Medical College. So, Shobik, you can share your screen and start presenting the normal acid-base balance in the body. Shobik, please. Shobik, you are trying to share your screen? Screen is visible. Shobik, you can start.
Shovik, your screen is visible, but you're not audible. Shovik, you're not audible. Please go back to the app and unmute yourself, and then open PowerPoint. Click on Join Audio at the bottom of the screen. Shovik, there's an option Join Audio that will come at the bottom of the screen. Please click that.
ভলিউমটা বাড়ালে তুমি শুনতে পারবে, কিন্তু তোমাকে আগে নিজেকে আনমিউট করতে হবে। Yes, you are audible. Please start.
Yes, sir.
Yeah, please start.
Good morning, everyone. Today, I'm going to present on the topic acid-base balance or homeostasis of blood pH. Now, acid-base balance is a physiological and a biochemical mechanism associated to body or blood pH. Now, what is pH? Now, pH is a hydrogen ion concentration. That is, it is the minus log of hydrogen concentration. Now, different compartment of human body has specific pH. pH has a role in enzyme activities. Now, why blood pH is altered? Addition of
Your
various
screen, Sobik, I can't see your screen.
Yes. Okay, sir. Okay.
It's visible, Makhanda.
Is visible, huh? Okay.
হ্যাঁ,
হ্যাঁ,
আমরা দেখতে পাচ্ছিলাম, হ্যাঁ।
আমরা দেখতে পাচ্ছিলাম, আবার এখন তুমি বলাতেও বন্ধ করলো।
Oh, sorry. Maybe.
ঠিক আছে, তুমি করো শেয়ার। স্যারের মনে হয় কিছু একটা স্লাইড হয়ে গেছিল।
Okay. I can see now. Okay, carry on.
Now, why blood pH is altered? Addition of various acids or alkalis by metabolic activities alters the blood or the body pH. Now, sources and types of acids and alkalis added during different metabolic life processes. Now, acid production. The types of acids in the body can be divided as volatile acids that can leave the solution and enter atmosphere. For example, carbonic acid. There are some fixed acids that do not leave the solutions. For example, sulfuric acid and phosphoric acids. And there are some organic acids that participates in or byproducts of aerobic metabolism. Now, acid and bases can be strong or weak. A strong acid or base is one that dissociates completely in a solution. For example, HCl, NaOH, or H2SO4. Now, weak acid or base is one that dissociates partially in a solution. For example, bicarbonic acid, CH3H6O3 and CH2O2 and lactate. Now, acid substances of the body are carbonic acid, phosphoric acid, and sulfuric acid mainly. Now, organic acids are lactate, acetoacetate, and pyruvate mainly. Now, the alkaline substances of the body are citrate and bicarbonates mainly. Now, what is acid-base balance? Acid-base balance is a homeostatic mechanism carried out to regulate the altered pH of the blood and other body compartment to its normal constant range. It is the regulation of the hydrogen ions. The more the hydrogen ions, the more the acidic solution and lower the pH. The acidity or the alkalinity of the solution is measured as pH. Acid-base balance regulates the pH. Now, why it is very essential to regulate the pH? Acid-base balance maintains the blood pH at normal constant narrow range of 7.35 to 7.45. pH of the medium directly affects the enzyme activities. Optimum pH is an essential requisite for enzyme activities and normal metabolism. It is a prerequisite for regulating blood or body pH to maintain the normal or the optimal enzyme activities, normal metabolism, normal coordination, and normal health. Now, the factors regulating the acid-base balance are the blood and its buffer system, our respiratory system, and our kidneys. First line defense, that is the blood buffer system. The second line defense, that is the respiratory mechanism, and the third line defense, that is the renal mechanism. Now, the respiratory regulation, the chemical buffer system, that is they react very rapidly within seconds to minutes, and the renal regulation that takes minutes to hours to act. Role of blood buffer system. First line of defense in mechanism of acid-base balance is the blood buffer system. The acids added Now the extracellular buffers, the bicarbonate buffer, the phosphate buffer, and the protein buffer. Now, mechanism, action of buffer system. Buffers are mixture of weak acids
শোনা যাচ্ছে না, you are not audible. Dr. Shobik?
Dr. Shovik, we cannot hear you. Can you please check your audio again?
Or maybe his internet has started getting some problem. He's not moving the slides also, no?
Yes, sir. Dr. Shovik?
It's a request to the speakers to please share the slides from their laptops, because on your phone there will be calls coming in disrupting your internet connection,
Yes, yes.
or else you have to put your phone on flight mode and use Wi-Fi. Is Dr. Shobik there, or he got
So
disconnected?
he is still connected. I'm just asking what is the issue. Dr. Shovik?
Yes, sir.
Yeah,
Yes.
please share your slides and start.
Did your presentation get over?
No, no.
No, sir.
Please start again.
Yes.
Yes.
Now, buffers are mixture of weak acids and its salts. They resist change in pH of blood when small amount of acids or alkalis are added to the medium. Now, buffers act quickly but not permanently. Now the bicarbonate buffer system. The acid-base balance is primarily concerned with the bicarbonate buffer mechanism. Bicarbonate buffer is the chief buffer system of the blood. Sodium bicarbonate is the salt part of the buffer that neutralizes the strong and the non-volatile acids added to the blood. It constitutes alkali reserve, that is HCO3 minus. Now, bicarbonate buffer system acts in this way, where that when any fixed acids or organic acids are added, it adds the H plus ions, and that H plus ions is neutralized by the bicarbonate reserve, which is there in the body, which is formed by the our renal system. So that bicarbonate reacts with that H plus and it forms H2CO3, and that H2CO3 dissociates into CO2 and H2O, and that CO2 is excuse me, sir. Yeah, here we can see that example that that H plus HCl is reacting with any HCO3 and it forms the H2CO3 and NaCl. That H2CO3 will now dissociate into H2 and CO2, and that CO2 will be expired from the lungs. Now, the action of bicarbonate converts strong dissociable acids into weak non-dissociable acids, and so for example H2CO3 and the neutral salt without altering the pH. Now, weak acid, for example H2CO3 formed during buffering action of bicarbonate buffer is then expired out by the lungs. Thus, bicarbonate buffer is connected to the respiratory system. Bicarbonate buffer is also termed as the respiratory buffer. Now the alkali reserve is represented by the concentration of NaHCO3 in the blood. Alkali reserve concentration determines the strength of buffering action towards added H plus ions by the acid. More the concentration of alkali reserve, more is the buffering action, and vice versa. Now, blood buffers are effective as long as the acid load is not very high and the alkali reserve is not exhausted. Now, coming to the phosphate buffer or the urine buffer, when H plus ions added, they are neutralized or fixed by the alkaline phosphate and converted to acid phosphates. These acid phosphates then excreted out to the kidneys as acidic urine. Thus, phosphate buffer is connected to the excretory system. So, phosphate buffer is also termed as the urinary buffer. When an alkali enters, it is buffered by the acid phosphate, which is converted to alkaline phosphate, excreted in urine, making the alkaline urine. Now, coming to the protein buffers, it includes the hemoglobin. The carboxyl group gives the H plus, and the amino group accepts the H plus. The imidazole group of histidine present in hemoglobin structure has buffering capacity. Now, here we can see that in an anaerobic environment, the CO2 is produced, and CO2 is it enters the RBCs and it combines with water to form H2CO3. This H2CO3 then dissociates into HCO3 minus and H plus. This H plus is taken by the hemoglobin, and thus the pH of the system is not altered. Now, role of respiratory mechanism. Respiratory system plays a second line of defense mechanism of acid-base balance. Role of respiration in acid-base balance is short-term regulatory process. H2CO3 formed from the bicarbonate buffer is exhaled out through respiratory system. Increased H2CO3 stimulates the respiratory center in the medulla oblongata. This in turn stimulates the hyperventilation, which promptly removes the H2CO3 from blood by expiration. Exhalation of H2CO3 is as carbon dioxide by activity of enzyme carbonic anhydrase of the lung. Blood pH can be adjusted through respiratory mechanism by changing the rate and depth of breathing. Low H2CO3 concentration in blood depresses the respiratory system, causing the hypoventilation, that is slow and shallow respiration. This retains the H2CO3 in the blood. Respiratory mechanism is powerful, but only works with volatile acids, that it doesn't affect the fixed acids like lactic acid. Now, here we can see the events happening in lungs and tissues. In tissues, there are deoxygenated hemoglobin, which goes to the lungs for oxygenation. In lungs, there are plenty of oxygen. So this deoxygenated hemoglobin is converted to oxygenated hemoglobin, and H plus is released. This H plus then combines with the HCO3 minus coming from the alkali reserve, and it forms H2O and CO2, and thus this CO2 is expired in the air. Thus the pH is maintained. Similarly, in the tissues, this oxygenated blood goes to the tissues, and oxygenated hemoglobin then releases the oxygen and becomes a deoxygenated hemoglobin. And here the HCO3 is formed in the tissues. Role of renal mechanism. Renal mechanism is the third line of defense mechanism. It is a long-term regulatory process. The acid and alkaline phosphate formed during the phosphate buffering system are filtered out from the blood and excreted out to the urine. Thus, phosphate buffer system is directly controlled by the renal mechanism. Renal mechanism conserve and produce bicarbonate ions, that is alkali reserve. Renal mechanism is the most effective regulator of blood pH. If kidney fails, the pH balance also fails. Now, the renal system maintains the acid-base balance through reabsorption of bicarbonate ions, excretion of hydrogen ions, excretion of titrable acids, for example, acid phosphates, and excretion of ammonium ions by the glutaminase activity. Now, let's see how the kidney maintains the acid-base balance. Now, first, the reabsorption of bicarbonate. Now, here we can see the tubular lumen, the renal tubular cells, and the blood. So, in the tubular lumen, there comes bicarbonate that is filtered from the PCTs and the proximal part of the tubules, and it combines with the H plus to form the H2CO3. This H2CO3 is then dissociated by the carbonic anhydrase activity into CO2 and H2O. This CO2 then enters the renal tubular cells, and then it again combines with water to form the H2CO3. This H2CO3 and then dissociates into H plus and HCO3, and thus this HCO3 is then again reabsorbed into the blood. So in this way, the bicarbonate is conserved, the urine is made free of bicarbonate, and there is simultaneous excretion of H plus. Now coming to the excretion of titrable acids. Here in this case, the titrable acids like alkaline phosphates is dissociated into for example, here the sodium alkaline phosphate is there. It's dissociated into sodium and the sodium hypophosphate. This sodium NaHPO4 minus and then combined with H plus to form NaH2PO4. That is the acid phosphate. This acid phosphate is then excreted, and thus the titrable acids are excreted in the renal tubules. Now this is a measure of acid excreted by the kidney, and also the number of milliliters of N/10 NaO is required to titrate 1 liter of urine to pH 7.4, and this shows the role of phosphate buffer. Now excretion of H plus ions. Excretion of H plus ions is already described, that the H plus coming from H plus, which is there in the tubular lumen, combines with the alkaline portion in alkaline portion present in the lumen, and it forms a weak acid. And then this weak acid with the help of carbonic anhydride is excreted. Similarly, in the renal tubules, CO2 is combined with H2O, and this forms the carbonic anhydride with the help of carbonic anhydride is formed to H2CO3. This H2CO3 is then dissociated into HCO3 minus and H plus. This H plus is then excreted through the ions. So here in this way, the elimination of non-volatile acid can be done. Excretion of H plus occurs in the PCT. Regeneration of bicarbonate is also happening, and the H plus combined with non-carbonate base and is excreted. Now the excretion of ammonium ion. So now excretion of ammonium ion, the ammonia is mainly obtained from the deaminase, that is the glutaminase activity, and here you can see the glutamine with the help of glutaminase is converted into glutamate and NaH and ammonia. This ammonia is then excreted into the tubular lumen, and it combines with the H plus to form NH4 plus. This NH4 plus can't diffuse back and is excreted. 2/3 of the body acid load liberated in the form of NH4 plus. Now the rate of correction. The buffer function almost instantaneously. The respiratory mechanisms take several minutes to hours to act, and the renal mechanisms may take several hours to days. Now the respiratory and renal regulation of pH. When an acid is added to the system, the first line of defense against the pH is activated. That is the chemical buffer system. Chemical buffer system has 3 parts: the bicarbonate buffer system, the phosphate buffer system, and the protein buffer system. They try to control the pH when adequate HCO3 minus reserve is there. When HCO3 minus reserve get exhausted, then comes the second line of defense of the pH, that is respiratory mechanism and the renal excretion mechanism. Here we can see that when H plus is added to the system, the second line of defense mechanism getting activated, that is in the kidney, the pH decreases, and this excess of H plus ions in the kidney is excreted by the kidneys in the form of H plus secretion. Similarly, when the pH decreases in the lungs, the respiratory system in the brainstem is activated, and the respiratory rate and depth is increased. Thus, CO2 is given off in this process. So, the mechanism of regulation of acid-base balance can be divided as buffer system, which causes a temporary solution, the respiratory mechanism that provides a short-term regulation, and the renal mechanism that causes a permanent solution. And thus the urine pH is maintained less than the urinary pH, so that H plus can be secreted by the kidneys. The urine pH is mainly maintained between 4.5 to 9.5, and this mechanism of acid-base balance eliminate non-volatile acids buffered by the cations and also maintain the alkali reserve.
Dr. Shobik, you have presented
sir.
well, you have covered almost everything, but when you are describing the normal pH balance of the body, you should talk a little about anion gap also. Because when we discuss about the various abnormalities like metabolic acidosis, alkalosis, respiratory acidosis, we need to know the mechanisms of compensation for each disorder. And we also need to know whether, if there is acidosis, whether it is a high anion gap acidosis or a low anion gap acidosis, because that helps you pinpoint the cause sometimes. Because, in diabetic ketoacidosis or, when there is increased lactic acidosis in trauma patients, dehydration patients, you would expect the patients to have a high
anion
gap. When you're talking about the normal physiology, it is an important portion of that normal physiology where you have to talk about the anion gap. It is an important aspect.
Okay, sir.
Okay.
Okay, sir.
And a bit about cellular respiration and the oxidative process that goes on, because that is also a part of the acid-base mechanism. Not directly, but how it works is like, suppose there's a patient of metabolic acidosis, and there's something called base deficit or base excess. That also you should have talked about a little. Why base excess or base deficit is an important parameter, because sometimes you might try to correct it with sodium bicarbonate, which is not recommended. Why? It appears sometimes it appears obvious that, okay, when there is base deficit, I should give bicarbonate, but that's not always the case. You are not rather told not to give bicarbonate. Why? Because that will deteriorate the cellular acidosis, because at the cellular level something else is going on, the carbon dioxide goes in. So a bit about oxidative processes going on in the cellular level has to be talked about when you're talking about normal pH. Okay, rest of it you have covered well. I would ask Shah sir to add something if he wants.
Yes, this anion gap is important for deciding about the management part also. And Shobik, sometimes on the background of, in some surgical condition, on the background of metabolic alkalosis, kidney can pass acid urine.
Yes.
What is that mechanism called as? Paradoxical aciduria?
I was also thinking about this.
But on the background of alkalosis, there may be paradoxical aciduria.
Yes, sir.
So this mechanism is a different way of compensation. It is not, the usual way of compensation. So why it is occurring, when there is concomitant hyponatremia, severe hyponatremia, it is not to preserve the potassium ions. It is to rather preserve the sodium sodium cations when there is concomitant severe hyponatremia along with dehydration and metabolic alkalosis. The body starts producing acidic urine, causing paradox.
To conserve sodium, we now start excreting hydrogen ion in spite of metabolosis.
So this portion also needed to be covered.
Okay, we can pass to the next speaker. Dr. Prashanji will speak on common acid-base disturbances in the body.
Dr. Shavik, please stop your speech.
Good morning, our respected faculty members and our participants. I am going to present acid-base disorder and interpretation of ABG. Primary acid-base disorder are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Metabolic acidosis, primary acid-base disorder characterized by fall in bicarbonate and pH, secondarily decrease in PCO2. Loss of the base bicarbonate via the GI tract or kidney, diarrhea and proximal renal tubular acidosis, overproduction of metabolic acid in the body, ketoacidosis or lactic acidosis, ingestion or infusion of acid or potential acid, salicylate or ammonium chloride, failure of uh, H plus excretion by kidney, renal failure, high anion gap metabolic acidosis, fall in bicarbonate, simultaneous increase in unmeasured anion normochloremic. Here its interpretation of normal gap versus elevated gap acidosis. Causes of high anion gap metabolic acidosis: lactic acidosis, ketoacidosis. Ketoacidosis comprises of diabetic, alcoholic, and starvation. Renal failure, both acute and chronic. Toxin, ethylene glycol, methanol, salicylate, and propylene glycol. Normal anion gap metabolic acidosis includes loss of bicarbonate, plasma chloride, increased hyperchloremic, and no change in unmeasured anion. Three causes. Causes of normal anion gap metabolic acidosis includes gastrointestinal, which includes diarrhea, intracutaneous fistula, pancreatic fistula, ureterosigmoidostomy, and renal causes renal acidosis with hypokalemia, both proximal and distal renal tubular acidosis. Renal acidosis with hyperkalemia, which includes type 4 renal tubular acidosis. Drug induced with AC inhibitor, angiotensin receptor blocker, aldosterone antagonist, trimethoprim, cyclosporin, tacrolimus. And other causes includes acid loads, ammonium chloride, hyperalimentation, expansile acidosis due to rapid saline administration. Urinary anion gap is a design to differentiate normal anion gap metabolic acidosis of GI cause diarrhea from renal cause. Provide an estimate of urinary ammonium production mechanism. Excess hydrogen ion binds with ammonia and excrete as urinary ammonium ion. Urinary anion gap can be measured with sum of sodium and potassium with and minus chloride. Normal value include minus 25 to minus 15 MEQ. Negative urinary anion gap causes are diarrhea, hyperchloremic acidosis. Positive urinary anion gap, renal tubular acidosis. Here, interpretation of the urinary gap: sodium plus potassium minus chloride. In first, and responses of metabolic acidosis: buffer system absorb hydrogen ion. Renal compensation include increased hydrogen ion secretion, increased bicarbonate generation. Respiratory compensation includes hyperventilation lead to decreased POCO2. Symptom of metabolic acidosis. Clinical presentation in metabolic acidosis is chiefly due to manifestation of underlying disorder and manifestation of metabolic acidosis. Respiratory causes: Kussmaul's breathing, CVS, increased susceptibility for cardiac arrhythmia, resistance to catecholamine, sympathetic overactivity. And CNS causes are lethargy, disorientation, coma, stupor, muscle twitching, headache. Other changes includes chronic acidemia and hyperkalemia. Treatment of metabolic acidosis: specific management of underlying disorder and alkali therapy, correct volume and electrolyte deficits. Indication for alkali therapy: when blood pH drops below 7.15 to 7.20, severe acidemia. When bicarbonate falls below 10 MEQ, needs prompt treatment because a small Additional fall in bicarbonate can cause a large fatal drop in pH. Respiratory compensation requires heavy muscular work. If for prolonged period can cause fatigue of respiratory muscle. Latter lead to respiratory acidosis as ventilation fails. Treatment of hyperkalemia also needed with metabolic acidosis. Aim of alkali therapy. Blood pH returned to safer level of about 7.2. Bicarbonate level to maintain at around 15 MEq or increases by 8 to 10 MEq per liter. Amount of bicarbonate required can be calculated by this formula. Desired bicarbonate minus actual bicarbonate into 0.5 into body weight in kg. Disadvantage and risk of bicarbonate therapy. Hypernatremia and volume overload, especially in congestive cardiac failure or renal failure. CNS acidosis and hypercapnia, hypokalemia, hypocalcemia. Overshoot or rebound alkalosis in organic acidosis, that is ketoacidosis, lactic acidosis, as organic anions convert to bicarbonate. Stimulation of phosphofructokinase activity enhance lactate production and worsen acidosis. Metabolic alkalosis. Metabolic alkalosis is characterized by increase in the serum bicarbonate, high pH, compensatory increase in PeCO2 due to alveolar hypoventilation. Pathogenesis of metabolic alkalosis. Initial increase in serum bicarbonate by endogenous and exogenous cause, excessive secretion of net daily production of fixed acid, disproportionate loss of chloride, maintenance process, decreased bicarbonate excretion, chloride depletion, potassium depletion, and extracellular fluid volume depletion, magnesium depletion. Causes of metabolic alkalosis. Exogenous bicarbonate loads, acute alkali administration or milk administration syndrome. GI causes includes vomiting, gastric aspiration, diarrhea, villus adenoma. Other causes include diuretic, hypercalcemia, hypothyroidism. And metabolic alkalosis with coexisting hypertension, primary hyperaldosteronism, Cushing syndrome, renin secreting tumor, metabolic alkalosis, irreversible genetic defect like Zettelmann syndrome, Bartter syndrome, Liddle syndrome. Chloride responsive alkalosis, low urinary chloride concentration, less than 15 MEq, gastric acid loss, diuretic therapy, volume depletion, renal compensation for hypercapnia. Chloride resistance alkalosis, elevated urinary chloride more than 20 MEq per liter, and primary mineralocorticoid excess, severe potassium depletion associated with volume expansion. Response of metabolic alkalosis. Buffer system donates hydrogen ion, renal compensation, hydrogen ion generation, bicarbonate segregation. And respiratory compensation, which includes hypoventilation, increased PCO2. Symptom of metabolic alkalosis: decreased myocardial contractility, arrhythmia, respiratory hypoventilation, pulmonary microatelectasis, ventilation perfusion mismatch, CNS, which includes decreased cerebral blood flow, confusion, mental obtundation, neuromuscular excitability, and others includes muscle weakness and polyuria. Treatment of underlying cause: the saline chloride volume responsive alkalosis, aim adequate correction of volume chloride and potassium deficit. So we administer IV isotonic saline with KCl or isolate G infusion, H2 inhibitor or proton pump inhibitor, KCl supplementation, spironolactone or carbonic anhydrase inhibitor. Avoid or discontinue exogenous alkali. Dialysis may helpful in patients with severe metabolic alkalosis, volume overload, or renal failure. Saline resistance metabolic acidosis: treat the underlying cause. Supportive treatment such as spironolactone, KCl supplementation, and sodium restriction. Respiratory acidosis: when pH decreases, PCO2 in this case increases. Respiratory compensation in acute case, when 1 millimole increase every 10 millimole increase of PCO2, and chronic when more than 24 hours required. 3.4 millimole bicarbonate increases every 10 millimole of PCO2. Serum bicarbonate usually does not exceed 38 MEq per liter due to compensation. If bicarbonate more than 30 MEq, think of concomitant metabolic alkalosis. Respiratory acidosis causes CNS depression, like drugs, opioid, sedative, anesthetics, obesity, hypoventilation syndrome, stroke. Neuromuscular disorder includes neurologic, uh, polio, GB syndrome, tetanus, botulism, chest wall restriction, pleural effusion, empyema, pioneal fibrosis, chest wall, kyphoscoliosis, scleroderma, and chylosing spondylitis, obesity, severe pulmonary restrictive disorder like pulmonary fibrosis, parenchymal infiltration, pneumonia, edema, abnormal blood CO2 transport, decreased perfusion, heart failure, cardiac arrest, pulmonary embolism. Symptom includes respiratory tachypnea, dyspnea, CNS increase intracranial tension, CO2 narcosis, disorientation, headache, lethargy, coma, and CVS includes tachycardia, wounding pulse. Others includes peripheral vasodilation. Treatment underlying cause. Oxygen therapy needs careful titration in case of chronic respiratory acidosis, as can lead to further reduction in alveolar ventilation and aggravate hypercapnia drastically. Mechanical ventilator support may also be needed. Respiratory alkalosis, most common abnormality in critically ill patient. Increase in pH and decrease in PCO2 is the primary cause. Primary process hyperventilation, acute pH alkalemic, PCO2 decrease, 2 millimole decrease of bicarbonate for 10 millimole of decrease in PCO2. Chronic pH, in case of chronic, pH normal, normal PCO2, normal or near normal, PCO2 decreased. In 5 millimole decrease of bicarbonate for 10 millimole of decrease in PCO2. Causes of respiratory alkalosis. CNS causes includes central nervous system stimulation includes pain, anxiety, psychosis, fever, cerebrovascular accident, meningitis, encephalitis, tumor, trauma. Hypoxemia or tissue hypoxia, high altitude septicemia, hypotension, severe anemia. Drugs or hormones, pregnancy, progesterone, salicylate, cardiac failure, stimulation of chest receptor, hemothorax, flare chest, cardiac failure, pulmonary embolism, and some miscellaneous cause like septicemia, hepatic failure, mechanical ventilation, heat exposure, and recovery from it. Symptom includes some CNS symptom like stinging, circummoral numbness, tetany, decreased intracranial tension, light head. Others include hypokalemia, hyponatremia, hypochloremia, decreased free sodium, serious decreased cardiac contractility, and arrhythmia. And treatment. Treat the underlying cause. Mild alkalosis with few symptoms needs to direct treatment. Oxygen supplementation is essential along with etiological diagnosis and treatment. In absence of hypoxemia and hyperventilation needs reassurance and rebreathing in a paper bag. Pre-treatment with acetozolamide minimized due to hyperventilation at high altitude. Some mixed acid-base disorder also found. Mixed acid-base disorder is defined as independent coexistence of more than one primary acid-base disorder. The most common mixed disorder is mixed metabolic and respiratory acidosis. The most detrimental mixed disorder are mixed metabolic with respiratory acidosis and mixed metabolic with respiratory acidosis. Here are some common example of mixed acid-base disorder. Metabolic in cardiac arrest, hypo and shock and diabetic ketoacidosis, there we found metabolic acidosis and respiratory acidosis both. In salicylate intoxication and gram-negative sepsis and liver failure, we get metabolic acidosis and respiratory alkalosis simultaneously. In case of CO2 and patient with diuretics and metabolic alkalosis with severe hypokalemia and respiratory weakness leads hyperventilation. In this case, we get metabolic alkalosis and respiratory acidosis simultaneously. In case of liver failure with vomiting and patient on ventilator with continuous nasogastric aspiration, we get metabolic alkalosis and respiratory alkalosis simultaneously. In case of diabetic ketoacidosis with vomiting and vomiting with severe volume depletion causing lactic acidosis, we get metabolic acidosis and metabolic alkalosis simultaneously. In rare case, triple mix acid-base disorder is also detected, where we get metabolic acidosis, metabolic alkalosis with respiratory alkalosis. For example, alcoholic patient with vomiting, and in COPD with hypercapnic patient, metabolic acidosis, metabolic alkalosis with respiratory acidosis. Here we get triple mixed acid-base disorder. Thank you.
Dr. Proshanjit, you have presented exhaustively, but I must tell you that from a surgeon's point of view, it is not possible for us to go into so much detail of acid base all the time. We need a working knowledge. Now, what working knowledge do we need? First of all, we need to be aware of the common settings in which we will face this kind of patients. First of all, maybe a head trauma patient or any other cause of respiratory failure. The patient may have CO2 buildup leading to respiratory acidosis. Then we have, patients with tachypnea, rapid carbon dioxide washout, we may have respiratory alkalosis. Metabolic acidosis we will have in patients with trauma, dehydration. That is one of the lethal triads which will make you decide that you do a damage control surgery, maybe along with hypothermia and bleeding disorders. This is considered one of the lethal triads. Then you will have certain conditions like certain endocrine conditions which may have some metabolic alkalosis or acidosis. Patients with a diabetic patient whom you want to operate might be having ketoacidosis. You do a urinary ketone, it's positive, then you look for the sugar, it's high, it is a diabetic ketoacidosis, and arterial blood gas will show acidosis. So it helps in differentiating between diabetic ketoacidosis and hyperosmolar non-ketotic coma. So these kind of patients will have. Then a patient of renal failure you need to operate. Those patients have hyperphosphatemia. They do not have the phosphate excretion mechanism intact, the bicarbonate reabsorption mechanism intact. So those patients again are very liable to develop all these kind of disorders. Then certain patients like, who have undergone procedures like ureterosigmoidostomy, you may expect, and you are doing some other procedure, you need to do a preoperative optimization. You will expect this patient might have a hyperchloremic metabolic acidosis. Or a patient of gastric outlet obstruction, when you are preparing the patient for operation or monitoring the patient, before operation, during operation, you have to be careful that the patient is not having metabolic alkalosis. If it has, then you do certain interventions. Now, first of all, you have to have the scheme of things very clear in your mind. How do we diagnose acid-base disorders? By an arterial blood gas nowadays, every hospital, every ward has it. The first thing you look at is the pH. If the pH is acidic, then next thing you look at is the PCO2 and the bicarbonate. If bicarbonate is low, then it must be metabolic acidosis. If PCO2 is high, then it must be respiratory acidosis. Again, if the pH is alkaline, bicarbonate is raised, it must be metabolic alkalosis. Metabolic alkalosis. If the carbon dioxide is low, PCO2 is low, then it must be respiratory alkalosis. Now, sometimes what will happen is when there is metabolic acidosis, that bicarbonate is low, the PCO2 may be normal or it may be high. If it is high, then what will you think? Then you will think it is a case of concomitant metabolic acidosis as well as respiratory acidosis. However, if bicarbonate is low and also carbon dioxide is low, PCO2 is low, you will know that the compensatory mechanism has started acting. So PCO2 and HCO3 minus and pH will help you make a diagnosis. Next, what do you look at? You look at the base excess, you look at sodium chloride, etc., to know what is the base excess, what is the anion gap, to help you in pinpointing the cause. Again, base excess is like a peritonitis patient having fever. So some mischief is going on. The patient is having metabolic acidosis with a base excess. Correcting the base the excess or deficit, whatever is the base deficit with bicarbonate, is like treating a patient of peritonitis with fever with paracetamol instead of operating on the patient. So you do not have to treat the symptom or the number, the base deficit. What you have to focus on is from base deficit, sodium chloride, etc. Try to pinpoint the cause of the metabolic disorder or the pH disorder, and you try to treat the cause. So when you approach the patient, the first thing you do is an arterial blood gas. You keep the pH and the different parameters in mind. make a simple flowchart in your mind, like I just said, and come to the common diagnostic points. So many causes, so many causes of different types of disorders will not be very handy in your day-to-day practice. So now over to sir, if sir wants to add something.
Yes, Prashanjit, you are supposed to speak on some interpretation of ABG. So you would have given some scenarios with ABG and with the values. How do you interpret this as acidosis or mixed disorder? So I was expecting that, because that was a question in MS examination, interpretation of ABG. So ABG paper shows you a number of parameters: pH, PCO2, PaO2, then base excess. So there are some interpretation of each of these parameters.
Yes, sir.
And then better that you give some real-time scenario and interpret what is this in the ABG. Okay.
Yes, sir.
One more
I
thing
think
I would like to
running
ask,
short of time, we can pass on to the management
Sir,
of
একটা
acid
question
disorder
করি
by
প্রথমে।
Dr. Behrul Huda. Behrul, you can share it.
যতক্ষণ বেরুল
Yeah.
স্ক্রিন শেয়ারিং স্টার্ট করছে, আমি প্রশান্তকে
বলো।
একটা কোয়েশ্চেন করছি যে metabolic alkalosis is more dangerous or metabolic acidosis is more dangerous, or acidosis is more dangerous or alkalosis? What saves you in acidosis is that the oxygen dissociation curve of hemoglobin becomes more favorable. It easily gives oxygen to the tissue when there is acidosis. Rather, in alkalosis, the oxygen dissociation becomes difficult. So that you have to keep in mind that, in trying to treat a patient of acidosis, if you overtreat the patient and land the patient up in alkalosis, then the patient is in more problem.
Yes, sir.
Is that the next speaker?
Sir, Dr. Behrul is not joined. I'm trying to contact him, but I'm not able to reach him. He was supposed to do the management part. Dr. Prasanjit
Yes.
has already.
Management, motamoti, ঠিক আছে, I mean, if he has not joined, management has been covered in parts, like in segments by the previous speaker.
sir.
One thing only I would like to add, there is a new agent called THAM, THAM, which is trophytamine. That is now being used in patients with base deficit instead of bicarbonate. That agent you have to know about. It is there in Sabiston. You just go through the pros and cons. It causes hypoglycemia, etc. That you have to be careful about. And the treatment of cause. Always remember, pH disorders is like, infection giving rise to fever. So some cause giving rise to this pH mischief. Only correction of pH won't help. Treatment of the cause. Okay. And acidotic patients, when you are dealing in the emergency, always go for damage control surgery rather than going in for something very heroic. Acidosis patients in the ward may sometimes need dialysis, and sometimes they may need to be ventilated, put on mechanical ventilation. A pH less than 7.3 is an indication for starting ventilation. And if suitable indications are there, those patients may need to be put on dialysis also. So these modalities of treatment, broad modalities of treatment, have to be kept in mind. Dehydration has to be corrected. If a patient is having continuous blood loss, that has to be corrected, like volume for volume, by the same component that is being lost. If a patient is having diarrhea, vomiting, all those things have to be corrected. So I think, sir, tahole ki korben?
Yeah, Prashanjit has partly covered the management, and one should keep in mind that before you go for correction of this acid-base disorder, you have to keep in mind the other parameters which are which needs to be corrected. Okay, and it is not wise to overcorrect metabolic acidosis, because in that case oxygen dissociation may shift to the left. So one has to balance the time of correction and the dose of bicarbonate to be given. Okay.
Thank you, sir.
And most of the time, if you correct the underlying disorder, these acid-base disturbances can come to normal. Okay. I think we are at 9 o'clock. Okay.
Thank you, sir.
Thank you, Didiman. Thank you very much.
Thank you.
Thank you, sir.
Thank you, everyone.
Thank you, sir.
Didiman.
হ্যাঁ স্যার বলুন।
প্লিজ MBBS ছেলেদের জন্য না একটা ই সার্টিফিকেট